Hello everybody, today we will be talking a little bit about one of the B complex vitamins called vitamin B1 thiamine. Now before we go into the vitamin B1 as thiamine, there are generally two classes of vitamins, one is known as fat soluble vitamins and one is known as water soluble vitamins. Within water soluble vitamins we have vitamin B complex and vitamin C. In vitamin B complex, today we are going to talk about vitamin B1 thiamine. Now, when we talk about thiamine, thiamine is the water soluble vitamin, vitamin B1. Now, if we look at the structure of thiamine, the structure of thiamine is made up of two rings. One is known as the pyrimidine ring and one is known as the thiazole ring. Now, if you look carefully at the diagram, then we will get to see that this is the pyrimidine ring and this is the thiazole ring. Both the rings together are connected via a bridge or a methylene bridge, which is this CH2. This is the methylene bridge that connects both the rings, that is the pyrimidine ring and the thiazole ring. Now, like B complex vitamins, the storage capacity of vitamin B1 or thiamine is very minor. Approximately 25 to 30 milligrams of vitamin B1, that is thiamine, is stored in liver, brain, heart, kidneys and skeletal muscles. Those are the tissues which have maximum requirement of thiamine, but generally this much storage of thiamine is depleted within 2 weeks. So, if a person is on a thiamine poor diet and that continues for a greater period of more than 2 weeks, there are chances that the person might develop thiamine deficiency. The storage capacity can only sustain for approximately a period of 14 to 16 days. Now, the major function of thiamine is its coenzyme form, which is known as thiamine pyrophosphate or also known as thiamine diphosphate. Both can be used synonymously since pyrophosphate and diphosphate both involves the presence of two phosphate groups. Now, if you look at the side diagram, then we will see that the thiamine structure generally has an OH group here. This OH group, if this H is replaced by phosphate molecules, predominantly one phosphate, then it is called monophosphate. If there are two phosphates, then it is known as thiamine diphosphate or thiamine pyrophosphate. This coenzyme form is the major requirement for multiple of the biochemical reactions. So, this is the general introduction about thiamine. Now, we need to learn a little bit about what are the different sources from which we can get thiamine and how much thiamine actually do we need on a daily basis. Now, if we want to list the dietary sources, then one of the predominant dietary sources will be green peas. Sunflower seeds are excellent sources of vitamin B1 or thiamine. Other than that, fish is a very good source in cases of non-vegetarians. For every general person who consumes rice, unpolished raw rice becomes a very good source of thiamine, because thiamine is predominantly present in very high concentration in the aleuron layer of the rice. But as we start polishing rice, that is turning rice into more and more white, with the obsession of consuming white rice, there is a gradual loss of thiamine because the aleuron layer is being removed. And it is said that if the rice is polished too much, the thiamine concentration can decrease by as much as 50% of its original capacity. Other than that, the two other great important sources of thiamines are legumes, again unpolished legumes. If we polish the legumes, again the thiamine concentration keeps on decreasing. In non-vegetarians, pork meat is also a very good source of thiamine. Other than that, nowadays in US and other countries, they have started fortifying cereals, mainly wheat, barleys, with vitamin B1 or thiamine, as a result of which thiamine deficiency cases have been slowly on a decline. But in majority of the underdeveloped countries, thiamine deficiency are still seen because of the lack of fortification of cereals with thiamine. Now, considering this dietary sources of thiamine, we can see that any person who consumes unpolished rice would contain or would get their daily requirement of thiamine. Now, how much thiamine do we actually need on a daily basis? The amount of thiamine that is required on a per day basis or a recommended dietary allowance, short form known as RDA, is approximately 1.2 milligrams per day for men, and for women it is somewhere around 1.1 milligrams per day. Obviously, this requirement in cases of women is in the non-pregnant stages. If the female is pregnant or the female is lactating, in such cases the thiamine requirement generally goes up. It goes up somewhere around 1.2 to 1.3 milligrams per day because of the excess requirement by the developing fetus in cases of pregnancy, or through the milk where the child gets the thiamine requirement or meets his thiamine requirement from the maternal milk sources. So, in such cases the amount of thiamine that is required by a pregnant or a lactating female would be higher than what it is for a non-pregnant or a non-lactating female. Now, coming to thiamine metabolism, how is thiamine metabolized? Now, in the topic of thiamine metabolism, we will be covering about the digestion and absorption of thiamine and transport of thiamine and how it is ultimately eliminated out of our body systems. Now, generally when we talk about thiamine, thiamine is present in the diet, and how do we absorb the dietary thiamine? That becomes a very important component of thiamine metabolism. So, let us look at the absorption and transport of thiamine. The thiamine that is present in the diet is generally predominantly present in the form of thiamine, which is in the diphosphate or the pyrophosphate form, or in few cases co-carboxylase form is also present. But this is not the only form. Small amounts of thiamine is also present in the diet as free thiamine. So, if the thiamine is present in the free form, then it can be absorbed very easily, whereas if it is present in the diphosphate form or the pyrophosphate form, then the gut enzyme, that is phosphatase enzyme, will first remove the phosphate and convert the thiamine diphosphate or pyrophosphate into free thiamine, and this free thiamine can then be absorbed by entering into the enterocyte or the intestinal epithelial cells. Now, the predominant absorption of thiamine occurs in the upper intestine, wherein there are two modes of absorption. One mode of absorption is the sodium dependent ATP mediated active transport, which can transport thiamine against the concentration gradient also, whereas the other mode is the passive transport or passive absorption, which is also there. Now, if a person takes thiamine and the amount of thiamine exceeds 5 milligrams on a dietary basis or a per diet basis, in that case the passive absorption can also start to play a role in the absorption of thiamine. But if the amount of thiamine present in the diet is less than 5 milligrams, in that case the passive absorption does not play a role, and at that point only the active absorption is utilized for transportation and absorption of thiamine into the intestinal epithelial cells from the GI lumen. Once the thiamine enters into the intestinal epithelial cells, after entry into the intestinal epithelial cell, the thiamine would be first converted into thiamine monophosphate by a phosphorylation reaction, and this thiamine monophosphate is then transported into the blood, where it combines with albumin, acting as a transient storage mechanism and allowing efficient transport of which and in blood the predominant forms of thiamine that is present is in thiamine monophosphate, although there are some views that small amount of thiamine diphosphate is also present as a transport form, but major transport form being thiamine monophosphate. This thiamine monophosphate, once it comes across a target tissue or a target cell, the albumin is left behind and the thiamine monophosphate enters into the cell. Once it enters into the cell, it is converted into thiamine diphosphate or thiamine pyrophosphate, which has the biological activity by acting as coenzymes or cofactors for multiple enzymatic activity. Now, this thiamine that is present inside the cells, it does its biological activity, and after its biological activity is over, that is approximately an half-life of 9 to 18 days, this is excreted and eliminated majorly via urine. But in case a person is consuming a very high dose of thiamine, in that case the half-life of thiamine can be reduced and it can be as low as 1.5 to 12 hours on a daily to daily basis that it would be excreted in cases of urine. So, in this way we see that the dietary thiamine is effectively transported in the form of thiamine monophosphate, which upon entering into the cell gets further phosphorylated into thiamine diphosphate, which does its biological activity. after around 18 days it is eliminated via urine. So, thus we see that if a person consumes thiamine at day 1 and does not consumes any thiamine till day 15, at the end of which by the end of day 18 all the thiamine from the system would be eliminated via urine, thereby needing or necessitating the absorbance or presence of thiamine or consumption of thiamine on a daily basis, so that thiamine deficiency does not occurs. Now, when we talk about the absorption of thiamine, then in that case the quality of food also matters, because the thiamine generally present in the food is susceptible to degradation if it is not stored properly, or if it is stored for extensive periods like 6 to 8 months or beyond that. Now, there is a study that says that if we store foods containing thiamine for more than a year, there are chances that their loss of thiamine happens, and as long as the transport and as long as the storage occurs, there is a greater loss of the thiamine. Now, not only that, thiamine is also relatively unstable and can be destroyed by poor cooking habits. Now, what do you mean by poor cooking habits? Generally, thiamine is stable up to the boiling point of water, and it is stable in the acidic water. But the moment there is an alkalinity or the pH is high and the temperatures reach across or reach beyond 100 degrees centigrade, there are chances that the thiamine would be lost. Some amount of thiamine is also lost when people throw the cooking water. So, therefore, in such cases there is a possibility that the bioavailability of the thiamine from the dietary sources may be reduced because of improper cooking habits or improper cooking methods. Other than that, food can also contain some amount of factors called anti-thiamine factors, which might inhibit thiamine absorption. Now, this anti-thiamine factors have been classified into two categories. That is, one that contains an enzyme called thiaminase. This enzyme thiaminase, if it is present, this will break down the thiamine structure and prevent the thiamine from being absorbed. So, the thiamine is not effectively available for absorption. Now, if you look at this portion, the presence of thiamine in the foods containing shellfish, ferns, tea, betel nuts and coffee, if we look at that, if a person consumes all of this, there are chances that it will reduce thiamine absorption. Now, how does that happen? If a person consumes shellfish and if it is eaten raw, or he takes ferns, that is, he is on a veg based diet, or he is stranded in a environment where the ferns are only the predominant source of diet. In such cases, this shellfish, if raw, and ferns, they contain the enzyme thiaminase, and this thiaminase enzyme, if it is present, it will break down the thiamine that is present in the other dietary sources, rendering it unavailable or unusable. Whereas, if a person consumes huge quantities of tea, betel nuts or coffee, even decaffeinated, in that case tea, betel nuts and coffees, they contain a factor called anti-thiamine factor. This anti-thiamine factor, they can go and bind to thiamine present in the foodstuffs. So, in such cases, the bioavailability of the thiamine would be decreased for absorption. So, the thiamine absorption can be reduced in case there is a enzyme thiaminase that is present if it degrades the thiamine, or the presence of anti-thiamine factors which will go and bind to thiamine and prevent the absorption of thiamine. So, thus we see that the food has to be very controlled in cases to have appropriate or maximal absorption of thiamine. Now, why do we need thiamine? What are the biochemical functions for it? Thiamine is generally utilized as a coenzyme, and the coenzyme form of thiamine is known as thiamine pyrophosphate or TPP or TDP, thiamine diphosphate. This thiamine pyrophosphate or thiamine diphosphate, it is utilized in the metabolism of carbohydrates, and it is also utilized in the metabolism of branch chain amino acids like leucine, isoleucine and valine. Now, here we are talking about mainly the human metabolism pathways wherein thiamine is utilized. In lower organisms and bacteria, there are other metabolic pathways where thiamine can be utilized, but we are now concentrating concentrating only on the human metabolic aspects. So, we are talking about thiamine in the metabolism of carbohydrates in the human systems and the metabolism of branch chain amino acids like leucine, isoleucine and valine in human systems. So, how is thiamine important in the biochemical reactions in carbohydrate metabolism? Now, in carbohydrate metabolism, thiamine is required for three major enzymes. The first enzyme being pyruvate dehydrogenase. This pyruvate dehydrogenase catalyzes the conversion of pyruvate to acetyl-CoA. That means it acts as a link that connects the glycolytic pathway, since pyruvate is the end product of glycolysis, and combines it with or connects it with acetyl-CoA, which is the starting material for TCA cycle. So, the link reaction that connects glycolysis with TCA cycle is catalyzed by the enzyme pyruvate dehydrogenase, which converts pyruvate to acetyl-CoA and requires thiamine pyrophosphate. The second enzyme that requires thiamine pyrophosphate is known as alpha ketoglutarate dehydrogenase, which is required in the TCA cycle, or which is an enzyme of the TCA cycle. The reaction that is catalyzed by this enzyme is alpha ketoglutarate is converted into succinyl-CoA by the enzyme alpha ketoglutarate dehydrogenase. So, thus we see that both the reaction, that is pyruvate to acetyl-CoA and alpha ketoglutarate to succinyl-CoA, catalyzed by the enzyme pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase, they both require thiamine pyrophosphate. So, how does this reaction proceeds? Pyruvate would be converted into acetyl-CoA, or alpha ketoglutarate would be converted into succinyl-CoA. In the reaction, carbon dioxide would be given out, and NAD, which is known as nicotinamide adenine dinucleotide, would be converted into NADH plus H plus, and the enzyme, that is pyruvate dehydrogenase or alpha ketoglutarate dehydrogenase, would require thiamine pyrophosphate or TPP. In addition to that, it would require lipoic acid, which is also one of the coenzymes, and it also requires FAD, known as flavin adenine dinucleotide. So, thus we see that these are two very unique reactions wherein TPP is utilized, and the amount of coenzymes required by the both enzymes are nearly same, and these are very good examples of reactions called oxidative decarboxylation, where carbon dioxide is removed and oxidation reduction is happening during the reaction. So, these are two examples in the carbohydrate metabolism linking glycolysis and TCA, wherein TPP is, or thiamine pyrophosphate is required. The other reaction where thiamine pyrophosphate is required is in the HMP shunt pathway, also known as the hexose monophosphate shunt pathway, which is a secondary metabolic pathway of or oxidative pathway of glucose without any generation of ATP, but this is very important to generate certain important components like NADH and ribose 5-phosphate that would be required by the body. Now, in the HMP shunt pathway, there is a reaction occurs wherein xylulose 5-phosphate combines with ribose 5-phosphate, and together they are converted into glyceraldehyde 3-phosphate and pseudoheptulose 7-phosphate. This is a reaction which is catalyzed by the enzyme transketolase. This enzyme transketolase requires thiamine pyrophosphate or TPP. Now, this reaction, what you see here, is a reaction wherein there is interconversion of sugars from one form to the other form, whereas xylulose is a 5-carbon sugar and ribose is a 5-carbon sugar. So, 5 plus 5 carbons, total 10 carbons enter into the reaction, and which are then split into 3-carbon compound glyceraldehyde and 7-carbon compound pseudoheptulose. So, this is how again TPP can be utilized in the breakdown of interconversion of sugars in the HMP shunt pathway or the hexose monophosphate shunt pathway catalyzed by the enzyme transketolase. Now, the next important reaction or pathway where TPP is utilized is in the metabolism of branch chain amino acids, mainly leucine, isoleucine and valine. Now, this reaction, that is the 3 amino acids leucine, isoleucine and valine, they are first converted into their corresponding keto acids or alpha keto acids, where leucine is converted into alpha keto isocaproate, isoleucine is converted into alpha keto beta methyl valerate and valine is converted into alpha keto isovalerate. Now, during the initial steps, the TPP requirement is not there. So, the first step would convert the corresponding branch chain amino acids into their corresponding alpha keto acids. Once these alpha keto acids are generated, then the alpha keto acids are further broken down, and it is this at this point where thiamine pyrophosphate would be required. The alpha keto isocaproate, which is generated from leucine, is converted into isovaluryl CoA. The alpha keto beta methyl valerate, which is generated from isoleucine, is converted into alpha methyl butyryl CoA, and the alpha keto isovalerate, which is generated from valine, would be converted into isobutyryl CoA. Now, for this conversion or the breakdown of the corresponding alpha keto acids into their final products, the enzyme that is utilized is known as branch chain alpha keto acid dehydrogenase. It is this branch chain alpha keto acid dehydrogenase enzyme that requires TPP or thiamine pyrophosphate. Now, in case a person has deficiency of thiamine pyrophosphate, in that case this enzyme branch chain alpha keto acid dehydrogenase will not work, and if this does not work, then in that case it might lead to accumulation of the alpha keto acids like isocaproate, alpha keto beta methyl valerate or alpha keto isovalerate, and their corresponding branch chain amino acids valine, leucine and isoleucine. So, if such an accumulation occurs, then it leads to a disorder known as MSUD or maple syrup urine disease, which is generally characterized by the accumulation of branch chain amino acids and their corresponding keto acids that may happen due to deficiency of the enzyme branch chain alpha keto acid dehydrogenase. The deficiency could be either genetic, that is the enzyme itself is absent, or it could be deficiency of TPP that would lead to inactivation of this enzyme. In either case, there would be accumulation of this branch chain amino acids and their keto acids, and that would lead to a disease called maple syrup urine disease, which is characterized by profound mental retardation and presence of maple syrup or maple syrup odor in urine that is seen. So, these are again important pathways which would be utilizing TPP or thiamine pyrophosphate, and in case thiamine pyrophosphate is absent or is deficient, these pathways would be severely affected. Now, in case there is a thiamine deficiency, then what is the deficiency disorder that we see? The deficiency disorder that is seen in cases of thiamine deficiency is known as beriberi. Now, the word beriberi comes from a Sinhalese word which means I cannot or weak. Now, this is what is the clinical criteria or clinical term that is given for thiamine deficiency. Now, in what cases do we see thiamine deficiency? Thiamine deficiency can be seen in case where there is a low or lack of thiamine intake. Now, this lack of thiamine intake can be caused due to either containing foods which are poor in thiamine, number one, or it could be containing foods that have those factors which decrease the bioavailability of thiamine. For example, when we looked at the antithiamine factors, that is tea, coffee, betel nuts, in such cases even if thiamine is present in diet, the bioavailability may be decreased. Or if a person consumes shellfish or ferns, in such cases also there is a possibility that the thiaminase enzyme will degrade thiamine and that will impair thiamine absorption. So, that can lead to decrease in the amount of thiamine intake. Or in certain cases where the requirement of thiamine suddenly goes up. For example, in cases of pregnancy or lactation or severe infection where the thiamine requirement severely goes up and the dietary intake fails to match up with the consumption requirement. In such cases, there is a possibility that the person might start suffering from thiamine deficiency. Or in cases of diarrhea or in diuretics where there is an excessive loss of thiamine either through the GI tract or through the urinary routes. In such cases also there is a possibility that the amount of thiamine would not be sufficient or the serum levels of thiamine would be severely depleted. Other than that, if a person has any GI issues, for example, there is a malabsorption syndrome like celiac or tropical sprue, or the person has intestinal disorders which does not allow the absorption to occur, or the person is alcoholic or he consumes alcohol. In such cases, there is a possibility that thiamine absorption might not work properly and thiamine deficiency might set in. Now, if a person has thiamine deficiency, we saw that the disorder that caused was beriberi. Now, generally there are three different types of beriberi known as wet beriberi, dry beriberi and Wernicke-Korsakoff syndrome. Now, why do we or how do I classify beriberi into three different varieties? The classification of beriberi into three different types depends on the amount of intake of thiamine and the amount of intake of carbohydrates and the amount of physical activity and the amount of alcohol consumption. Now, in case a person consumes high carbohydrate diet and he does excessive physical activity, along with thiamine deficiency, he might show signs and symptoms of wet beriberi. Whereas, if he takes low thiamine or there is thiamine deficiency and his carbohydrate intake is also low and physical activity is also less, he can show signs and symptoms of dry beriberi, whereas Wernicke-Korsakoff syndrome would be exclusively seen in cases of chronic alcoholics. Now, let us look at the three different varieties so as to differentiate how do we see or how do we classify as wet, dry beriberi and Wernicke-Korsakoff syndrome. Now, wet beriberi. Wet beriberi is generally caused due to thiamine deficiency, along with which there should be increase in carbohydrate intake and there should be increase in physical activity. Now, what happens when this triad meets, that is increased carbohydrate intake, increased physical activity and thiamine deficiency. Now, in such cases the physical activity allows the person to have greater ATP requirement or makes the person ATP requirement go up, and as the ATP requirement goes up, the amount of glucose metabolism via glycolysis also increases. Because of increase in glycolysis, there is an increase in the conversion rates of glucose to pyruvate. Now, this pyruvate was generally supposed to be converted into acetyl-CoA and it was supposed to enter into TCA cycle, but again the enzyme pyruvate dehydrogenase that is required for conversion of pyruvate to acetyl-CoA requires thiamine pyrophosphate. So, in such cases, if thiamine deficiency is there, therefore, in such cases pyruvate would not be converted into acetyl-CoA. So, that leads to increased pyruvate accumulation. Now, this pyruvate that is being accumulated would then be converted into lactate so that glycolysis continues, and this in turn increases the lactate concentration. Now, this lactate concentration when is increased, it causes peripheral vasodilation, and once peripheral vasodilation sets in, this leads to edema. Edema basically means there is an increase in the peripheral accumulation of fluids. Now, when edema sets in, this decreases the return or venous return of blood, as a result of which the heart that is pumping the blood, the amount of blood that comes back to the heart at the end of one cardiac cycle becomes less, as a result of which the heart has to work overtime in order to supplement the blood to the various tissues, leading to high cardiac workload, and this high cardiac workload sets in cardiomegaly or enlargement of heart, and this enlargement of heart, if it continues for a very long time, it might lead to increase in heart rate, that is seen as tachycardia. There might be an increase in blood pressure which is seen as high BP, which ultimately might affect the heart, leading to myocardial injury, which might be expressed as a chest pain which may be acute or chronic. So, thus we see that wet beriberi mainly involves cardiovascular symptoms which is caused due to thiamine deficiency, high carbohydrate intake and high physical activity. Whereas, on the other hand, if a person has thiamine deficiency, but the carbohydrate intake or calorie intake is poor and relative physical inactivity is present, in such cases there would be a gross problem in ATP production. The reason for that being is the person is consuming lesser amounts of glucose, as a result of which the glycolytic rates also will decrease because of the decreased availability of substrate. In addition to that, whatever glucose is being consumed, that is producing pyruvate, but that is not being converted into acetyl-CoA, therefore reducing an ATP production limits, and if some amount of acetyl-CoA is generated from the oxidation of fats, then in that case also that acetyl-CoA entering into TCA cycle would not be effectively generating energy because of the inhibition of the enzyme alpha ketoglutarate dehydrogenase. all of this leads to a greater amount of ATP deficiency, and this ATP deficiency might affect the central nervous system and also the peripheral nerves and myelin formation, which might lead to decrease in the neuronal activity at the central nervous system or also at the periphery, causing peripheral neuropathy, which is manifested by tingling sensation in arms and limbs or the periphery, and it also might show neurological manifestations which might lead to mental impairment. In addition to that, ataxia, that is incoordinated movements, may be seen, which is again attributed to low ATP or low ATP concentration in the central nervous system, and also vomiting may be seen, which is seen as a reflex action in cases of some of the neurological impairments or neurological manifestations. So, thus we see that dry beriberi mainly deals with central nervous system issues, whereas wet beriberi deals with cardiovascular issues, and the reason for that is same, that is thiamine deficiency, but the associated conditions which are required, that is the calorie intake, it differs. In dry beriberi, calorie intake will be poor, whereas in wet beriberi, calorie intake has to be high, and the physical activity in cases of wet beriberi has to be very high, whereas in cases of dry beriberi, the physical activity has to be low. So, this is with respect to dry and wet beriberi. Now, coming to the last clinical symptom of thiamine deficiency, that is Wernicke-Korsakoff syndrome. This Wernicke-Korsakoff syndrome is generally seen in chronic alcoholics. The reason for that is alcohol, if consumed, inhibits the active transport mediated absorption of thiamine. So, in case where a person is consuming alcohol and his diet contains thiamine, but the amount of thiamine is less than 5 milligrams per diet, in that case the absorption of thiamine would be severely impaired. But if he is consuming more amounts of thiamine, that is greater than 5 milligrams, in that case passive absorption might occur, and alcohol cannot inhibit the passive absorption. Alcohol can only inhibit the active absorption. So, this is the reason why in some chronic alcoholics we see Wernicke-Korsakoff syndrome, while in others Wernicke-Korsakoff syndrome may not be seen, because it all depends on the amount of thiamine that is taken in along with alcohol. If the amount of thiamine is low, then the active transport that is mediated or that is utilized for absorption, that would be severely impaired, whereas if the amount of thiamine is high, more than 5 mg, in that case passive absorption will allow some amount of thiamine to be absorbed. Now, in case of Wernicke-Korsakoff syndrome, the classical symptoms that is seen is confusion, ataxia and nystagmus. Now, nystagmus is to and fro movements of the eyeball, ataxia is incoordinated movements. All of them generally are attributed to low thiamine and corresponding low ATP concentrations. Now, in cases of chronic alcoholics, the thiamine absorption is severely impacted, leading to deficiency or impaired pyruvate dehydrogenase acetyl CoA reactions, and the alpha ketoglutarate dehydrogenase reactions are also impaired, as a result of which ATP deficiency is severely present, and because of which the brain does not get adequate amounts of ATP or energy in order to do essential functions like coordination of movements, then coordination of other activities, muscular activities. Therefore, all these symptoms set in. The other symptoms that are seen are painless vision abnormalities like double vision and inability to stand or walk without assistance, because the neuromuscular connections are not very well working because of the problem in myelination that is seen at the periphery. That may be seen because of ATP deficiency. Also, there might be hallucinations and agitations that might be attributed to low ATP concentration in the central nervous system, and also one of the major symptoms that is seen is confabulations, wherein the patient starts to make imaginary stories to fill the gaps in memory, and this is because memory conservation requires large amounts of ATP. Now, since ATP is deficient, the person is not able to consolidate memory for a very long periods of time, as a result of which there are large gaps in the memory which he starts feeling with imaginary stories. That is why you see sometimes chronic alcoholics, they make imaginary stories of doing something which they would have never done. So, these are few of the essential symptoms associated with Wernicke-Korsakoff syndrome. Now, in order to make a diagnosis of wet beriberi, dry beriberi or Wernicke-Korsakoff syndrome, the clinical symptoms might be enough, but in order to treatment or in order to treat such patients, I have to give him a thiamine dosage. Now, in order to determine the thiamine dosage, I have to find out actually what is his thiamine status. So, therefore, the assessment of thiamine status becomes very important. Now, how can I assess the thiamine status? Thiamine status might be assessed by directly measuring the amount of thiamine or its metabolites like thiamine monophosphate and thiamine diphosphate in plasma, or I can measure the urinary excretion of thiamine. Now, in case where urinary excretion of thiamine is more beyond the normal limits, in that case I would expect that there is an increase in the urinary loss, therefore, the amount of thiamine supplementation has to go up. The other best way of measuring thiamine status is measurement of RBC transketolase activity. Now, this is one of the estimated or one of the established modes of determination of thiamine concentration, where RBCs are extracted from a blood sample, and after the RBCs are extracted, they are lysed, and then the RBC transketolase activity is measured, and based on the RBC transketolase activity measurement, thiamine status is indicated. So, this is generally are the tests that are done for assessment of thiamine status. Now, all of these are important because thiamine is one of the key essential water soluble vitamins of the B complex group and is required in the metabolism of glucose and is very important for ATP generation. So, therefore, we need to be very careful about the thiamine status and the associated disorders. So, therefore, thiamine status and its metabolism assumes great importance in the prevention of beriberi. Now, the underdeveloped countries are at a risk of developing beriberi because of the poor dietary habits, whereas in the countries like US or UK, there has been fortification of cereals with thiamine. So, thiamine deficiency symptoms or thiamine deficiency cases are on a decline, but in poor countries, the presence of thiamine deficiency disorders are still at a very high risk, and it can be very easily treated by giving them a multivitamin supplementation of thiamine. So, therefore, thiamine is one of the key essential B complex vitamins. So, with that we conclude, and hopefully this would have been able to help you understand a little better about the metabolism of thiamine and its importance. Have a great day. Thank you.